Well, good morning, everyone. Welcome to the Colorado HFMA Virtual Fall Summit. I'm Jonathan Wick, the president-elect for the 2021 year. We want to take a moment to first recognize our annual business partners who not only provide financial support for our chapter, but also share their knowledge and expertise through speakers and presentations. Their support allows us to operate our chapter and bring our members quality education and resources, especially through this very challenging time. We hope that you look at them first if your organization is in need of their services or support. Our platinum sponsors are Athena Health, BC Services, Collection Center Inc., Continuum, Patient Co., PFC, PFS Group, Revenue Enterprises, TransUnion Healthcare, and WHA. Our gold sponsors are AccuReg, BKD, Clifton and Larson and Allen, Credit Services Company, Healthcare IP, KeyBank, Plant Moran, Guidehouse. Our silver sponsors are AppRev, Bessler, Brown Hyatt, Farber and Schreck, Colorado Health Facilities Authority, Coronas, Crossroads Health, Cyber Science, Hall Render, Para Healthcare Analytics, Strata Decision Technology, and Extend Healthcare. And our 2020 virtual sponsor is Commerce Healthcare. For today's webinar, we will be using the Q&A box located at the bottom of your screen. Questions will be answered at the end of each session. A link to download the presentation will be provided in the chat as well as an email after the webinar. If you need a NASPA certificate, please take note of this keyword, pumpkin. You'll need to complete a polling question during the webinar. There are 3 polling questions that will be required in order to get credit. This morning's revenue cycle panel is presented by Sarah Moore, Sadaf Tarani, and moderated by Aaron Ferlin. Sarah serves as the Director of Revenue Cycle at Valley View Health. She's been in that role since 2005. She is certified with AHAM and a certified outpatient coder. Sadaf is the Director of Operations and Patient Access and Scheduling at Children's Hospital. She oversees a team of 900. I'll bet she has lots of spare time. She is an EPIC EMR collaborator for the state of Colorado Children's Hospitals. She's a member of CACHE and also a NAHAM board member. And finally, Aaron, our moderator, is a senior account executive at BC Services. He's headquartered in Longmont, Colorado. He has 15 years of experience in healthcare. He's a Colorado native and has a bachelor's degree from Colorado State University, as do I. Go Rams. And Aaron, I'll give you the panel.
All right. Good morning, everybody, and thank you again, Sarah and Sadaf, for being with us. Everybody, we have 2 talented individuals here from 2 incredible health systems. So really excited to have you here with today. To just pull up my presentation here. So while I'm pulling that up, just wanted to say, for all of you guys impacted by the fires here, our hearts go out to all of you and your communities and everything. It's been some tough times we're dealing with right now. So let me hit, sorry, this is not pulling up here. There it is. Well, while I get this pulled up here, we can start here with Sarah. Sarah, you want to tell us a little bit about? So Sarah's from Valley View. Do you want to first tell us a little bit about your role here in Valley View and exactly how your structure works there?
Sure. We're an independent rural hospital. We have 78 beds licensed, and we offer quite a few services that are unique to not only the service area, but Colorado. So we have one of 3 radiation therapy machines in the United States. So we have a robust cancer center program. We have a cardiology department that includes cardiac cath, and we are going to be starting in the next year open heart surgeries with a CV doctor. So things that you wouldn't normally see in a small community, Valley View Hospital is offering our community and our patients. I am the Director of Revenue Cycle at Valley View Hospital, and we have 15 clinics that I am also over. 2 of them do their own billing and follow-up, but the rest of them fall under me to do all their follow-up and collections.
Perfect. And you all have what I understand, you got a pretty impressive 21-acre medical campus up there too.
We do, yep.
Well, perfect. And then Sadaf, do you want to just talk about children's first? I know you got 4 freestanding hospitals across the state, but
Sure.
go ahead if your thunder there.
Yeah, so Children's Hospital Colorado, we are an academic institution. We have about 564 licensed beds. We have 4 freestanding hospitals, about 12 outpatient locations that include ED urgent care kind of spread out among those different locations. We see about 600,000 outpatient visits a year, in addition to about 168,000 ED urgent care visits a year as well. We are US News World Ranked, and we are one of the first pediatric organizations that went live with Epic. And I'm the Director of Patient Access and Scheduling. My team and I really support all of the front-end operations of the revenue cycle. So if you think about everything from scheduling, registration, check-in, referral management, insurance authorization, financial counseling, in addition to all the patient engagement tools. So self-service check-in kiosks, patient portal, and any sort of messaging platform that we're using to connect with our patients and families. So it's a really large scope.
Yeah, it sounds like you've like John said earlier, you're not busy at all, are you?
No, not at all.
So you brought up front end, and so I think maybe let's start with registration. I think that's always a hot topic is registration quality. So due to COVID, what things have changed on that front? Has it gotten better? Is it even more challenges? What unique things have you seen there on the registration side?
Yeah, that's a good question. I think registration quality has always been a hot topic, like you mentioned. And I think for our organization, it has been a little bit of a struggle, only because there's not a lot of tools or accuracy measures to really capture or measure if we are actually doing registration accurately. So we just recently went live with a registration scorecard that my team and I worked really hard on. And we're working through it right now, and it's proving to actually serve really well. In terms of COVID, actually registration has never been more important than it has now because of COVID. As you know, we're doing the drive-through testing for COVID, so all of the demographic information has to be captured accurately. But when we think about registration, someone walking in or doing registration over the phone, that's a little bit different now because we don't have the luxury of actually having that face-to-face patient contact. So we have to be sure that we're capturing accurate registration at the time of scheduling the COVID drive-through testing and making sure that we're capturing the right insurance information that is eligible. So I think registration has been impacted in the sense of it's never been more important than it has right now. So,
right, definitely.
Yeah.
And that was my assumption as well too. But and so, what about Sarah? What do you see up at Valley View, up in kind of you're in a different instead of being a big city, being in a mountain community. What kind of things are you seeing up there?
Well, we're really we've been kind of stable with the COVID cases. And so we do have 2 drive-throughs. We have a respiratory tent that we've been utilizing, and as well as the clinics have drive-through options so that patients can come get tested. But the same thing is set off is, it's so important in registration right now to make sure we're getting that information, because we are utilizing as a hospital the HRSA uninsured program. And so to make sure and attest to those patients that don't have the insurance that these are covered, we're finding a lot of the community has heard from, news and things like that testing is free. And so they don't even want to give us their insurance information. They just want us to write it off. So it's been a challenge to try to follow up with those patients or follow up with an order that just has a name or a phone number, and getting that information to get those claims billed so they are paid and waived by their insurance companies has been a challenge for my patient access team for sure.
Yeah, I think even us as an extended business office in the call center, we've been seeing a lot of that too. And I think it's just comes down to educating the patient and all of that. And that's a tough thing to do. But I think we're all, considering what's happening, we're all doing a pretty good job with the cards we're dealt here. So I kind of want to segue into telehealth then. We've seen a lot of telehealth really was, I wouldn't say it wasn't a topic before, but not to the scale as it is now. And so, Sarah, what are you guys doing with telehealth and getting patients registered for that, but also making sure you're still getting paid and billed and all that goes in with that?
So we're using a lot of products, especially in our clinics that utilize Athena. We're using a Cure for You app, using different kinds of apps to utilize and work with the telehealth. It has exploded. We were planning on doing telehealth before all of this started, and we were slowly getting it ramped up one clinic at a time and utilizing it because of the rule setting. But with COVID, it really kind of put it in the forefront. And I would say at this point, telehealth is our biggest visit in all of our clinics, to not only have that first initial order to get the COVID test, but also just your basic services. And people don't want to come into a building. They want to be able to stay home and see their physicians. So it has taken over our clinic visits for sure.
Definitely.
In volume.
Definitely. I've done 3 of them already here this year. We have a 5-month-old daughter, and we've already done a couple televisits with children's and also up in Fort Collins Youth Clinic. So definitely been seeing a lot of that too. So Sadaf, what are you seeing in at children's?
Yeah, very similar to what Sarah mentioned. We had a telehealth program stood up for, several years, but we went from 100 telehealth visits per year to 100 almost half a day. So as soon as COVID hit, we had to convert all of our in-person visits to telehealth pretty quickly. And I think the pendulum that shifted really reinforced to providers that now it's not a choice. It's no longer a choice. We have to actually move forward with telehealth. Before, providers were a little hesitant. They weren't sure. They didn't like the technology. They wanted the in-person visit. But now, because of COVID, they really were, forced to say, okay, if I'm going to have to continue patient care and, meet volumes, I'm going to have to do this. So it really shifted the pendulum such that providers didn't even ask a question or blink an eye. We implemented technical support because that was a lot of concern for our providers. And then we quickly shifted all the in-person visits to telehealth. Now that we're a little bit more stable, we've kind of gone back down. So before it was about a 80% telehealth visit, 20% in-person visit. Right now we've shifted quite a bit, and now we're back down to 20% telehealth visit, and we're slowly racking back up to that 60% in-person visit. So we're trying to find a good balance, and I think it's going to be an ongoing challenge in terms of what is that right balance for our patients and families and the provider group.
Yeah, and we're finding a lot of the other, with the release of new codes that Medicare has said, oh, you can do telehealth for PT and OT and ST. Those are things that we had in the Department of the Hospital. Cardiac rehab just currently went live just on the 14th of October. So adding more services, more service lines, and then dealing with the nuances of billing telehealth and which payer wants which code, and do they want the place to service O2? Do they want the place to service the patient's located? What modifier do they want? So it's been a challenge. We have a spreadsheet that we send out almost monthly that is version 8, version 9, version 10, because things keep getting added.
Yeah, I've definitely seen that, and so I bet, like Sadaf was saying, I'm sure there's probably a lot of frustration initially with the physicians and trying to get buy-in and all of that. But at the end of the day, probably realizing, hey, this is the only way we're going to connect with our patients and our community, and it is what it is. So that that's great to hear of how you've overcome that, and how just like most all businesses, whether they be healthcare or not, we're constantly adjusting. We're moving with a very fluent environment that we've got going on here. So another thing I want to talk about here. So now that we're seeing a lot of patients virtually, but now we're kind of seeing them back in person again. Another hot topic this year with a lot of changes is price transparency. How are you dealing with that? So I know in Valley View, Sarah, you were talking about how you guys aren't posting contracts up there.
We are not. Yes, so we have decided, or the administration group has decided, that we're going to comply in some form or fashion, whether that's just getting a price estimator that's more robust to the patient, so they can put their deductible coinsurance, things like that they know of, in there, along with our historical data for those procedures. But we'll be posting the 300 shoppables, 70 of which Medicare requires, the 230 by our discretion. And yeah, we've decided that it's too large of an impact to the facility to post contracts. We would have a lot of insurance companies coming back to us asking for new contracts, and so they've decided that we'll give as much as we possibly can without harming the future of the facility being independent.
Yeah, definitely. Not a light decision, and kind of have to weigh a lot of the pros and cons there. So Sadaf, what are you seeing down in Children's?
Yeah, similar. We are not posting our contracts, but I think with my position being more on the front end, we're really taking the route of how do we stand up, an effective cost estimate program such that patients and families can really have that transparent knowledge up front and understanding and clear expectation really on what they could potentially be financially responsible for. So we just launched off our project around cost estimates with a new functionality in Epic, and there'll be a year-long project. But we do have a price transparency work group that continuously talks about, how do we connect the dots with the families, and how do we really give them the right education and tools so that patients and families feel comfortable and they know how to navigate kind of all the different costs and prices. And it's hard because I think as an organization, we're trying to navigate that too, just as much as the patient. So I think it's definitely a hard thing to kind of manage, but patients want it. And I think they're becoming more savvy, and I think they have ways of figuring out which CPT code they're, going to be seeing for the service. So I think we're really excited about the cost estimate project and launching that off, and hopefully helping to close the gap a little bit in terms of price transparency.
Perfect. This question goes out to both of you. If you were to give any kind of recommendation of where you're getting information and a good place to weigh some of this, where are you getting a lot of your information that you're basing your decisions on? Walk me through that process of kind of where you get it from, how you're reviewing it, who's reviewing it, and that process.
Decisions in terms of price transparency or cost estimates, or just in general?
Just in general.
Yeah. I think it's many of you that are listening and watching as we are colleagues among each other. And I think it's always nice to be able to pick up the phone and say, let me call my friend at, Boston Children's, or let me call so-and-so at another organization. I think learning from one another has been a huge help for at least us at Children's. We have colleagues across all different departments. So that's been really helpful. I think obviously, following the regulations that come out at a state level and a federal level, I think is helpful. But I think we're kind of reaching for any resources that we can to help us continue to, learn and kind of move forward.
Okay.
Yeah, and the same thing, a lot of listservs, a lot of webinars, and then a lot of reaching out to colleagues and saying, what are you guys doing? Who are you looking at to use? What are your plans? And trying to figure out, how do we help our customers the same way the hospital down the road is going to help them, and trying to keep that relationship to where they don't feel like they're getting a surprise bill, because we've tried our hardest with historical claim history as to what this is going to cost. It's so difficult, as you all know, in healthcare to get an accurate estimate, because so many things can happen with those patients when they get in there and have a procedure done. The physician sees something different, adds a procedure, and that increases the cost and the time underneath anesthesia. So it's been a challenge coming up with accurate, as close as possible, this is what you're going to owe for the patient, so that we don't have that backlash of, well, you told me it was going to be this and it's $1,000 more, or
Right, and that's where you have to go back to, like, that's why we call it an estimate kind of stuff. But,
right.
it's really hard with all that. And you mentioned collaboration with other health systems, and and that's what's beautiful about HFMA here. I know we've had a lot of webinars here over the last couple of months, and with a lot of some of these topics, and we're all collaborating with each other here. That's why I think today is really important too, so we can kind of get some questions on the floor here and help our people. We're all friends here. We're all our all common goal here is for improve patient health. So I do want to hop right back to telehealth right quick. I did have a question come in from an individual saying, have you been seeing physicians asking to regulate number of telehealth visits? Basically, the question is that and this person is a surgeon saying it's really hard to manage time with the telehealth method, and we've seen complaints from physicians about regulating time. And how have you seen it, and how have you dealt with that?
We have seen it. That has been a challenge for our physicians as well. Whether it's technical difficulties in getting on, you're expected to have 20 telehealth visits in a day, and each one you're hoping is 20 minutes. And if you have technical difficulties getting on and providing that service, then you're over into the next scheduled appointment. So that has been a challenge for our physicians, feeling like we are trying to say, okay, we know this patient wants to talk to you about this, and this is the diagnosis that they're discussing. How much time do you need? And making sure that we try to give them an appointment window that's sufficient for them to get through what they need to get through, including any kind of technical difficulties, because we don't have IT right there next to them helping them sign on. We do have nurses or medical assistants that can help them, or the office director go in and help them. But it has been a challenge, and just trying to make sure that we are setting those appointments in appropriate time frames for them, so that they can also see in-house as well if they need to.
So have you had to rely on if you had to get like any new software that you didn't have before for that scheduling, or were you able to utilize existing software?
Existing software.
Okay. And Sadaf, what about children's?
Yeah, very similar here as well. The providers, we never came in and said, okay, you have to have, for example, 100 telehealth visits per day. What the approach that we took was more of, let's make telehealth a primary visit type. So if you're going through clinically and you know that a patient clinically can't be seen via telehealth, that you have to see them in person, then that's when you make the switch. So we haven't really nailed it down or figured it out, and we haven't really stuck to a particular number. We're really allowing the flexibility between each specialty and each clinical medical director to do some sort of decision tree or triage of saying, okay, can my 100 patients that are scheduled today, how many of them can effectively and clinically be seen via telehealth, and how many actually really in person need to come in? And then in terms of the technical difficulties, what we're seeing is the patients that are, on the patient portal or have had telehealth visits before, or quite frankly are English speaking, don't really have a lot of technical issues. It's mainly those who are on a lower socioeconomical status, that are non-English speakers, that we're finding that patient population are the ones that are struggling with the technology. And then the physicians, we've done a really good job of really educating and training the physicians. And we have a small team of support that's on standby, obviously for a limited number of time during the day, but they are on standby to help the providers. But I think what we're hearing more is the technical difficulties on the patient side from kind of the non-English speaking, some of those that are not used to the telehealth. But we haven't really nailed down, you know, a visit or trying to say, okay, you have to have this many time. And then we also have not allotted more time within the visit for telehealth either. We said, okay, if you have a 30-minute, you know, follow-up visit, for example, that's 30 minutes. You got to make it happen within 30 minutes. We're not adding more time for your telehealth visit.
Perfect. So it sounds like you've got a pretty good strategy there for you know, doing the best you can. Obviously, you're not going to catch them all where, you know, a telehealth doesn't just become a precursor to an in-person visit. It sounds like you're kind of actively trying to, you know, really make sure, you know, you're using your time wisely, but you're also being considerate of the patient's time wisely too. So they don't have to do a telehealth and do an in-person if they really need to see that. So it sounds like you've got a pretty good strategy there. Sarah, are you guys kind of doing the same thing up at Valley View?
We are, yes. We're seeing the same thing with the ability, the use for our patients. So I know that the application that we're using sends the email to them. The office manager calls them and says, you're going to be getting on a visit in 5 minutes with the physician. Use this link, use this password. And they kind of go into a waiting room for the physician. And that way, when the physician's ready and gets on, it's go time for them. So
okay,
we don't have a set amount that they have to do. It's kind of the same thing as SIDOF and Children's, is that it's to the discretion of the physician. Do they think that they can see the patient telehealth, or is that something that needs to be bring the patient into the hospital or the clinic?
Perfect. And one last question regarding telehealth that come in was, do you foresee any reduction in volume because of telehealth at all?
We actually see an increase in volume because of telehealth, because of those patients who didn't want to come in to the facility now have the ability, or patients who are maybe out in the middle of the mountains and maybe have internet access, but they don't want to drive in the winter. I think it's going to increase in the winter, especially with the roads around here with 82 and just the remoteness of some of the housing. I think it's going to increase.
No, I agree. And like I mentioned earlier, there are things like I've had 3 visits myself and things that I normally might not have come in. I'm like, well, what the heck? I don't have to go anywhere.
Right.
I just got to take 15 minutes out of my day here and do it.
Mm-hmm.
Yeah, I've had my own telehealth visit. It was quite interesting. It was the first time that I have ever had it. And yeah, same kind of thing. It was like, I don't have time to go to the doctor's office and wait in the waiting room with a bunch of people. And it was an easy get online, talk to the physician.
Yep.
Show them my eyeball.
I know, it's like, oh,
it was a little thing. I was like, so that was a little strange, but it worked, and it was a unique experience for sure. So.
Yes, I definitely agree. But you know, that's where technology is amazing, and I think, you know, these next couple of years, as we've been seeing, you know, with AI and all kinds of AI and all kinds of other technology, just, you know, I think 5 years from now, we're just going to be like, wow, we didn't even think about these things. So I'm interested to, you know, have this conversation a couple of years from now. So. Like we've kind of been beating around the bush here of COVID. Of course, COVID has really put. It's changed our whole world. I heard someone say the other day, like it's the new 9/11, kind of, where everything from that point forward, across all businesses, all, you know, it's forever changed. And so, I guess we can start from probably the biggest concern, not even concern, the biggest topic on people is the PFS side, money, revenue coming in. What are you doing collection-wise? And I mean, I'm talking the front end, and I'm talking just payments in general. It doesn't even have to be, you know, if it's, we'll get to delinquent in a little bit, but what are you doing for billing? Any kind of unique processes you've adopted, or, you know, go for it.
No, we don't have any unique processes. Of course, utilizing the HRSA uninsured program, and so our self-pay uninsured has decreased because if they have the right diagnosis, if they have the right tests done, it can be covered by HRSA, and you're reimbursed at the Medicare rates instead of a self-pay rate that you may not get. At first, you know, we were closed for any kind of elective procedures, and so revenue was down, and I just had my staff just attack all the old stuff, get through the old stuff, work everything old, get that money in the door.
Yep.
To supplement the new money not coming in, and it really worked. We didn't really see a dip in what revenue was coming in. It was an actual increase versus revenue and reimbursement that we saw because of the hard work of the staff working those old accounts and just really having the time, because the new accounts were coming in into their work files. As far as self-pay, you know, we have our policies for our self-pay financial assistance policies, and we did allow for, we sent letters out to patients and said, you know, in this time, we'll give you an extra 60, 90 days. Call us, let us know what's going on. If you've lost your job, let's apply for assistance, and trying to work with them. But we have went back to full collection status and full billing status.
Okay. Yeah, that's kind of what we're seeing here too. You know, from a self-pay agency on our side, you know, we definitely did see some, you know, big drops there for a little bit there in February more of billing with that, and that's more on our side with the collection. So I've seen a couple of health systems in Colorado that fully stopped bad debt collections, and actually they're still stopped. What are your opinions on that?
Unfortunately, in these times, it's hard because patients don't have jobs. They don't have the ability to pay, but we still, as facilities, have bills to pay.
Right.
So people want paychecks. We did at Valley View have a reduction in staff to make sure that we met our budget goals. And so for us, it was, okay, we give 30, 60, 90 days extra. We will extend a payment arrangement out from 24 months for a couple extra months if we need to. If you can only pay $10 this month and then pay your regular payment next month, it's been a real tough balance with patients, especially in a small community, because they're like, I can't believe you're collecting in COVID.
Right.
And we still have bills to pay. The lights need to stay on. The nurses need to get paid. Doctors need to get paid. And we have our own bills that we need to pay that we can't just not pay. So
right.
It's been a tough conversation with some patients that,
right. And I'm sure
apply for assistance. Now that you don't have a job, you still are within our window of financial assistance.
Right.
Let's get you on there. We do have a robust plan. So a lot more assistance has been given in these times than normal.
And that was my question. And you answered my next question. I would say, have you seen a lot of increase in in financial applications? And
yes.
I'd be surprised if you didn't. Yeah, you make some definitely interesting. I think it was just, for our experience, and probably with you, just a lot of training with the call, with people, with the people on the front end, whether you're face to face or on the call of talk ops, and just coming at it of pay what you can, get in on a payment plan, we'll work through this together, but don't just go dark and let it just get way far out ahead of you. So anything that you want to add to that you've been seeing on the children's side?
Yeah, I would just say I agree with Sarah, very similar. We did not change any of our billing or collection practices. In fact, my colleague who's over that department worked really hard on doing something similar to what you did, Sarah, and making sure, they go through all the bad debt and collecting whatever they can collect from older accounts to kind of help close that deficit that we saw, the big dip in the revenue. And then our financial counselors obviously increased as well, just because of the economy and a lot of people going to unemployment. So we saw our payer mix quickly shift as well. And then our co-payments, I think as an organization at Children's, we've always been pretty generous, meaning we haven't been very stern or assertive in collecting anyways. So I think it kind of transitioned nicely to help out, within COVID. But our co-payments, they were required, and then we made them not required as a result of COVID. So that was kind of one slight change that we did in response to COVID.
Perfect. what other challenges, so we've talked about telehealth, we talked about price transparency, billing. What other things have impacted that you wouldn't have thought would be, there's some items out there that some challenges you face that you wouldn't have really even thought would be a challenge that you're dealing with?
Staffing and working from home, because of, the schools being closed or the county health department saying you have to be quarantined for 14 days if you have symptoms and things like that, trying to get those employees who normally don't work from home set up working from home within a couple days of whether it's their child that has to be sent home and quarantine, or whether they have symptoms and they can't come in and they're waiting for that test. And we're seeing it's taking 2 to 3 days to get a result for the test. So getting those employees up and running at home so that the productivity doesn't slow down. That's been our biggest challenge is making sure that accounts are still being worked and money's still coming in, but we're also allowing employees to work from home, which has been a big change for us to allow that. It's always just been exempt employees that were allowed to work from home. So having that, working together with the team of IT staff to be like, I just had an employee call me and say that she can't come in because she's got symptoms and she has to wait for employee health to call her to set her up an appointment to get to her PCP to have that telehealth visit, to come get the test and wait to see what's going on, because we did come back probably after 6 weeks into the office, and the office, we're off site. Part of the staff is off site. And so we kind of dispersed them all out into open offices and getting them moved so that they're not right next to their coworker. So that's been a challenge. And I think, the face masks, because the people who are out in the common areas have to wear their face masks all the time. And I had an employee say to me, it's good to see your smile, because she walked by my office door, because she's like, I haven't seen your face and I don't know if you're smiling or if you're mad or, what's going on. So I think that the whole feel of the room has changed for employees and trying to read people's eyes.
Totally. And it's been interesting with a 5-month-old too, wearing a mask. And it's like, when you take them off, like, she's like, oh my gosh, like there's a face under there, and it's just like, I'm interested to see like what kind of effects those have down the lines with a lot of our community.
Yeah.
I think we've all been seeing that. I think we've all relied very heavily on our IT teams. We've been super, thankful and blessed for IT teams where, maybe historically in the past, a team that, they're IT, but now just kind of realizing, wow, we had some great teams and collaborations working together to get, hundreds or thousands of people home. So Sadaf, how are you keeping your staff motivated at home?
Yeah, that's a good question. We just talked about that as a leadership team a few weeks ago. It's, before, when we had meetings in person, it was very agenda based. It was very, okay, we're going to start on time, we're going to end on time. And now that we're all working from home, we really have to pause and allow some space for people to just, pause, maybe have some personal conversation before we kind of jump right in. And I've seen that to help, and it seems so simple, but I've really seen that help our team members feel connected and engaged, when you kind of allow some space. And then we also require that, if we're having 10 meetings in a month, that at least half of them, you have your video turned on. So that way we can actually engage and see team members face to face. And then staying connected, maybe it's more check-ins, maybe it's more intentional questions of how are you and your family doing, and just allowing some space for that personal conversation, and then offering grace too, because it is a challenging thing to keep folks engaged, motivated, and feel like they're part of the organization when we're all remote. So it's definitely a challenge, but I think doing small things has definitely helped.
Yep. I know one of our managers, she has her team huddle every morning for 15 minutes, and they spend 5 minutes kind of sharing photos of something around their house or something they did with their family or kids during the day. And, and I really think that's opened up to a lot of, people getting
Mhm.
to know each other a little bit better that they might
Mhm.
not necessarily have done in the past. But every
Yeah.
office is a
Mhm.
little bit different.
Yeah, we've gotten professional at doing 2-minute icebreakers. So we'll rotate between leaders and we'll say, okay, each leader has to come up with a 2-minute icebreaker to start off the meeting. And it's been, it almost feels like back in elementary school when you have to, go into your first
Yeah,
day of class, what icebreaker you do. But it's been good. It's been good.
perfect. Anything else you want to add to that at all, Sarah? Or should we move on?
We can move on. Yeah, I don't have a lot of stuff that works remote. It's just in the one-offs now that we have to have it working.
So yeah, because that's what I've been hearing from a lot of. I think people are now kind of back up to 40%. I think 40. I think the rule is 50% right now, but I think a lot of people are kind of hovering under that 40% mark or 50% mark. So and I know those rules keep changing, extending. So we'll see what happens here. Apologize to backpedal here. I've got a couple questions that came in here, and I'm trying to do my best to answer them all in order. But back to what we were talking about, the question came in a couple minutes ago saying, what are you doing on the denial side in order to improve rev cycle results? So I'll let, whichever one of you want to take that one first.
I think Sadaf and I kind of talked about it, that
Yeah.
it all starts with the registration process, making sure you've got the right insurance, you've got that authorization, you've got everything in line so that when it does hit billing, you're not dealing with a lot of denials. We're fortunate at Valley View for the patient access team here is extraordinary. Our denials rate, our final denials rate is less than 1% of our gross revenue. We do utilize a denials management tool, and it talks with Meditech, because on the facility side we use Meditech. On the clinic side, it's Athena and a couple different other practice specific to the specialty. But for denials management, we've just utilizing that new system. We actually brought that up in January and started using it right before it hit, because before that
awesome.
before that denials management was manual. It was, you get a denial, you post it, the cash posters post a zero pay, it would show up in insurance follow-ups work file, and they would write up an adjustment that was a zero, like it's a medical necessity adjustment, it's an authorization, and I'm appealing. And so we would have all these initials, which were $0, and then if they appeal, we never knew what we were turning over. And now with this new program, we can see these are the denials and this is the recovery rate. So that's been really helpful for us.
Mm-hmm.
Yeah, and for children's, my colleague who's over the billing and collections, she does a phenomenal job of leading a denial work group that meets pretty frequently monthly, and they bucket denial by category, and it's a collaborative effort between all the revenue cycle teams to come together and do a deep dive and pinpoint, is there a gap in our process? Do we need to fix something in the system? And they do a really good job of quickly turning that around to recoup that money.
Yeah. And we have a revenue cycle team as well that includes the IT and patient access. And so my patient access manager, if it has to do with the front end denials, she gets that list and works through it, and then she retrains team and talks to them. And is it a specific insurance we're seeing? Is it a specific provider that's not providing all of the diagnosis or all the procedures that they're going to be doing? So it's definitely a collaborative effort to keep those.
That was the words
down.
out of my mouth. I was going to say it's a lot of collaborations, working with physicians and staff to create better coding practices, to improve.
Creating templates for the physicians so that they have a template for when they're ordering, because that's the one thing that we see a lot is coming from our ancillary clinics, where they're sending referral labs over to the hospital, and at that point, if it doesn't meet medical necessity, it's too late. We're not going to not test bodily fluid or any kind of lab that comes in, and we find that it doesn't meet medical necessity, and we're writing off a lot of labs. And so we worked with IT and we worked with the clinics and said, okay, what can we do for these 5 codes that we keep seeing denials for? Can we build you a template of the most common diagnosis that would meet that you could pick from if the patient has? And so that's really helped reduce those as well.
Awesome. Sounds like you guys are all doing the right things here, and staying ahead and
trying.
Yeah. And, you know,
One step ahead. You got to stay one step ahead of those insurance companies.
yeah, definitely.
Yeah.
You know, and that's why for your innovation, and everything, that's why we're just so incredibly blessed to have you two here today to really share these insights, because you guys have really been doing an awesome job with that. Sarah, I have a question here, and it's directed towards you. It says, what other financial IT systems do you use other than Athena? And do you have a decision support or financial group help with the contractual and bad debt analytics?
So we use Meditech. We use an InThrive product for the denials management and our collection workflow for self-pay and insurance follow-up. We use SSI for billing. But no, there is no collaborative group or financial decision group. We do have a contract manager who deals with all the contracts. So if we find that we're seeing issues with a particular payer on not paying per contract, we usually compile a list and give that to him to go directly to, or I'll go directly to our provider rep and ask, you know, can we get this lump of claims overturned because you guys aren't processing per our contract. That's been real difficult recently with the insurance companies because they like to slide in, oh, but did you notice on your contract it says our reimbursement policies, and they put something in a reimbursement policy that they put out on their website, and you have 60 days to contest it. So if you're not on top of your mail, if you're not on top of those little notices that come through, it's a challenge to then contest that and be like, well, this isn't per coding guidelines, or this isn't per CCI edit. This is just some random thing you decided not to pay us for. But we don't have, other than the InThrive denials management tool, we don't have any kind of collaboration group. Each individual insurance company or insurance follow-up is responsible for their denials within their work file. I think we may have lost.
We lost Aaron.
I think so.
Oh, did Aaron drop you guys? Sorry about that. I can go back into the Q&A and see if there's other questions there for you. Can you guys hear me?
Yes.
Yeah.
Oh,
Okay,
there he is. He's connected.
there he is.
There he is.
All right, there you are, Aaron.
Now my computer's back.
Okay, no worries.
So I apologize about that. I'm having that's the beautiful, isn't that what we're all dealing with?
Technical difficulties.
Can't hear you.
Yeah. Sarah, we're finding the same thing in terms of payers are denying and quickly, and then we're not exactly sure why they denied it. Like if we go back and everything's set, they'll sometimes just deny things, and if we don't turn that around quickly, it could quickly snowball if we don't catch that. So to your point, it's interesting how sometimes the fine print can get us in trouble if we're not on top of it.
It can, because I know just yesterday we were dealing with a non-payment of a code, and it was like, what do you mean it's not payable? It's payable by Medicare. What do you mean it's not payable?
Right.
Oh, because of reimbursement rule number 12,
right.
It's against their
like,
policy, they don't pay it, and it's like that's not our contract.
Right. Yeah. Good point.
So yeah, you have to be on top of it, because if you're not, I think it's almost like a test. If you send one through and it denies and you don't fight it, they're like, let's just keep doing it.
Right. That's so true. That's so true. Yeah.
So we had another question come in asking if you could speak a little bit more about how RevCycle works with your contract reps on the front end, so that when contracts with your payers are renegotiated, you limit future challenges regarding denials.
So I work directly with the contract manager. Most of our contracts have been the same contract for us for 15, 20 years. We just recently, in the past couple of years, have had payers come back and ask us for altered contracts. We're pretty fortunate. Most of our contracts are percent of charges, so we don't have a lot of those carve-outs that we have to deal with. But basically, I get all the mail sent to me for the contracts that come from the payers. I sift through it all, and I'm the one that directly does all the reporting for the denials. So I can see the denials every month firsthand as they're being adjusted off and appealed. And I just pick up the phone and start talking to my contract manager. This is what's happening, what's going on. This is what I need in the contract. If they're coming to you, make sure you have this written out so that we don't get caught. Like we had a payer try to change our timely filing, and it was like, you want us to send you things in 45 days? We don't get mail for 15 and then 30 days. And so it was basically working closely with him to say, this is what I need, and this is what I'm seeing. How can you help me get this overturned, or who do we talk to facilitate a better understanding of the contract?
So you haven't been busy at all.
No. And that's,
similar
one of the reasons why we're not doing the price transparency with our contracts, because we're pretty golden on most of our contracts. So.
Yeah, similar at Children's, we have a pretty strong contract management team that collaborates with all the different revenue cycle departments. And we collaboratively review the contracts to see, do we need to update anything? Do we need to go back to the payer based on denials that we're seeing? Do we need to have those conversations? Do we need to update any fine lines or fine print in the contract? And then if there's anything that impacts the front end, like let's say, a payer all of a sudden is making different auth requirements and that we are agreeing to, we'll get that education out to our front end team members quickly to make sure that everyone knows how to have those conversations with the families if things change. And then we have it posted on our website and all that good stuff to over communicate. So.
Awesome. Sounds like both the organizations are doing a really good job with all that, and that's awesome. So that was actually all, mainly all the questions that I had, and it looks like for the Q&A, we've answered all questions. We've got about 8 minutes left here. Just wanted to say to the participants, anybody else have any other questions out there? No questions, a bad question. If you're thinking about it, most likely somebody else, if not many other people, are thinking the same question. So don't be bashful at all. Throw some questions in there. We'd love to get them answered here in the next couple minutes to help you out.
And I'll just pop in and say, if it's easier as well, feel free to use the raise your hand option at the bottom of your screen, and I'll just unmute you and you can ask your question out loud if anybody else has some additional questions.
Nobody?
I actually have a question. I don't know with who is on as participants, but we're currently getting on the countdown of a certain payer, I won't name any names, who's wanting lab codes registered with them, or they will deny their claims. If there is not a unique identifier on the claim for each individual lab that you bill to this payer, they're going to not only deny the lab charge, they're going to deny the entire claim. And just want to put it out there that I've been sitting in on a monthly call with Oklahoma Heart and Pennsylvania and Idaho and a couple of the other hospitals here in Colorado to go to that payer and say, we're not complying. This is out of HIPAA standard. Has anybody else? What is the plan for their facility to deal with this payer?
See, we've got a hand raised here. I'm trying to figure out how to.
And if you all are aware of this, because I know I think a lot of people, like Sadaf said, you get these letters in the mail, and if you're not on top of it, you're not reading it. It could come to a surprise come December 1st if you haven't complied.
Perfect.
In January when you start getting your denials.
So Jessica, you're gonna have to help me out here with raised hand. I don't know. I'm technologically illiterate. Not sure how to do it.
Well, it looks like it went down. So Sarah, you might have actually answered or touched on it at one point here. Oh, but we have a question here in the Q&A box.
Yep.
I can go ahead and read that out for you. Patient payment plans were mentioned earlier. Have you seen an uptick in patients opting into those plans during the pandemic? How was that trending pre-pandemic because of the increase in high deductible health plans?
We have seen an uptick in patient plans. We offer a 24-month interest-free payment plan, and then we also partner with a company to do med financing. So we've seen a lot more med financing applications coming in because patients can't meet the 24-month payment plan minimum, and so we've been enrolling a lot more into the medical financing plans, and then also the increase in the financial assistance applications because we offer the financial assistance for insurance balances after the fact. So it's definitely increased significantly with doing the automatic payments as well, using their credit card online and doing those automatic payments so it just comes out, whether that's on a personal credit card, checking account, credit card, I don't know, but there's definitely been an increase.
Yeah, same at Children's. We've seen an uptick, about 20% of our financial assistance applications going up, 20% more than pre-pandemic. And then we don't do any sort of financing, but all of our payment plans, we went live with an automatic payment function last year, and we've seen an uptick in that as well. And I would anticipate it would continue to stay kind of pretty high. Yeah.
Perfect. So another question we have here is, some other Colorado hospitals are engaging in contracts with local government entities and other entities to expand business. Have your organizations begun to do this as well?
We are, without saying too much, yeah, we have met with the largest employer groups in the Roaring Fork Valley and discussed a collaborative contract with them so that their employees can get better rates at the hospital as a group, as a whole. So yeah, we have engaged in those conversations with the largest facilities and the largest employers, because Valley View actually is one of the largest employers in the Valley. So not only is our insurance, but yeah, getting a collaborative plan out there for the other large construction companies or trucking companies or oil field companies that are working around the Valley.
Yeah, and probably even, the college up there too. I know there's a lot there too.
Mm-hmm.
So what are you seeing on the Front Range side? Anything you're doing with Children's as well?
No, not that I'm aware of. Yeah, not that I'm aware of. I don't think we are.
Okay. Awesome. We got 2 minutes left here. And again, that's all the questions that have been asked. Just wanted to be respectful of your time too, and not go into any other topics, and just in case we get another question in here. Let's see. Well, I guess with that, where we can go towards the end is, do you have anything else that you would like to maybe add, to send people away with, any food for thought or encouragement?
We're all in this together.
Hang in there.
And yeah, hang in there. And thank you guys for having us. And my contact information is always available if anybody wants to reach out for any other questions for whatever reason. So happy to collaborate.
Mine as well.
Thank you.
Mm-hmm.